I welcome you all. Thank you for joining the Digital Agenda Forum. This space is recorded, so whoever misses, they can always go back and replay to catch up. We'll start straight away. I am Lilian Nagaba Nabwevale, and for the next hour, we are going to tackle one of the most critical conversations of our time. Today's topic is health ethics in the digital age, and we have a special focus on privacy, access, and the future of healthcare. The world is constantly evolving with many amazing innovations, including those in healthcare. Health tech is advancing every day, and the world is moving fast, becoming digital with the apps, electronic records, artificial intelligence. Of late, there is a new buzz of digital IDs. There is a global constant push for digital ID to become the gateway to healthcare services. So today we are going to look at this conversation through the lens of medical ethics and patient care. We are here to ask the tough questions. How do we protect human dignity, patient confidentiality, and equitable access to healthcare when everything goes digital? To guide us through this complex moral landscape, we are honored to have an expert who deals with these dilemmas on the healthcare front lines. Dr. Maurice Rutachinjira is a physician and research fellow. His experience is in direct patient care, which allows him or gives him a unique and vital perspective on how the digital age impacts real people sitting in the doctor's office. Dr. Maurice, thank you for allowing to be here to edify us. I want to confirm again that you can hear me before I continue.
Yes, I can hear you loud and clear.
Okay, so you're welcome, and to ground us and to introduce the format that we are going to follow tonight, we have questions that have already been sent in to the expert, and we want to thank everyone that has sent in questions prior to this discussion. Our expert will read them and answer them accordingly as he feels led to do the flow. These questions have been organized in a structured format to ease the discussion flow and to allow him to give us thoughtful, concise, and well-structured answers rather than just off-the-cuff reactions. However, I know that a number of us listening in will have brilliant follow-up questions or angles we have not considered in the questions that have been sent prior to this discussion. So for that, we invite you to use the comment section on our handle, this very handle that is hosting this space. It is Digital Agenda T. Digital Agenda T. Go there and see the post, the latest post we've put there for this space, and use the comment section there to post your comments and questions. Our expert will be reviewing those comments. After he has answered the pre-prepared questions, he will respond to the follow-up questions later too. So keep the conversation going online, be respectful, keep the questions coming in, invite as many people as possible to join this discussion and share the link widely. We will start by grounding ourselves in the core principles of medical ethics, and then we will move into the more challenging topics like data exposure and digital access. Our expert is going to explain the core principles of healthcare ethics in simple language that we understand. He's going to give us foundation ethical obligations of healthcare providers. He will show us how principles like patient confidentiality, informed consent, and justice, equal access to care, guide modern medical practice. And then concerning the sharing and exposure of personal health data, he will let us know how this can be handled in the digital age. We know that the healthcare profession traditionally really has always guarded patient information carefully. So as the world advances further into the digital age, what changes are coming in and what exactly changes when data becomes digitized and widely shareable? How sensitive is health data compared to other forms of personal data? What are the ethical risks if such data is exposed, centralized or misused? Where is the line between improving healthcare coordination and violating confidentiality? What are the safeguards that are existing before digitization is considered ethical? What safeguards should we put in place? And then we will say sincerely digitization is now ethical, considered ethical. Are we still able to maintain patient autonomy and confidentiality in this age? We have also always had healthcare professions saying that treatment must not be denied based on status or identity documentation. Now with this gateway of you must have a digital ID before accessing healthcare, we are asking, is it ethically acceptable to tie access to treatment to possession of a digital credential? How should healthcare systems treat patients who cannot access, afford, or use digital identification? Could such requirements unintentionally create medical exclusion? What would ethical implementation need to guarantee that no one is left behind? We have asked our experts to be real, like to be in the real world as much as possible and use lived reality when he's answering our questions tonight. Because we are asking, in practice, what challenges do vulnerable populations face when systems become digitized? How can healthcare modernizations happen without widening inequality? What should policymakers always remember when designing systems involving patient identity or data? What must never be compromised in healthcare, regardless of technology? What does an ethically sound digital health future look like? Those are the many questions that came in prior, and we believe Dr. Morris will answer them ably, and we will live edified, and we will know the way forward. We will know what to do and what to tell decision makers as these changes keep coming and the world continues to evolve. So we will let Dr. dive straight in, and the floor is yours, Doctor. Thank you so much for joining this call. Thank you.
Thank you so much, Ms. Lillian Nagaba, for the kind introduction and elaborate pace that you have set. I thank you for the opportunity you've given me and the whole the Digital Agenda Forum and the community. To those who do know me, these views are personal, and as well they do have an expert touch to them. So thank you. I'll try to be as elaborate as possible and as simple as I could be. And for the questions that I made, if I don't answer it appropriately, please feel free to bring it back. One of my weaknesses is talking a lot because I think I teach a lot, so sometimes I end up expounding too much on something. So I hope we'll go through all the questions in the 1 hour time that we do have together. And so I'll start off right away. Is this topic relevant? Yes, it is very, very relevant. And as I'm going to explain to you in the future, the few things that I have observed on ground and how we are, Uganda right now, I confidently say we are in the youthful stage of the digital transformation in the healthcare sector with what is happening in our regional referrals and our national referral hospital currently. And so I'm going to state what are the core principles of the healthcare, of the healthcare practice. And so worldwide, there are 4 principles worldwide, the 4 principles that all healthcare practitioners follow. We have autonomy, which means to be allowed to make a choice of your own, in simple terms. And then we have non-maleficence, where the healthcare has to make sure that whatever they are providing you does not cause you harm in any way. Like malice, non-maleficence comes from the word malice. So whatever you're doing should not be bad to you or cause you harm as a patient. Then there is justice, implying that the healthcare practitioner is more like a judge, I'll put it that way, has to make sure that whatever they are administering to the patient or to the given population and community is done in a fair way, equitable, that all populations can benefit, not only just a few and others are left out, so that we do not have any marginal, any subset feeling like it is being left out. And then finally, we have beneficence, that at all times, whatever is being proposed must be of beneficial. In scenarios where we have harm, for example, harm and benefit competing, whatever you're going to propose must be that is more beneficial to the patient. In other words, it has to be in the best interest of the patient. If I'm to give an example, just to elaborate when I talk about beneficence, just forgive me on this, but I'll just use this as an example just to illustrate. Sometimes some young women do want to get pregnant, and so when they conceive, at times they conceive false pregnancies. We call them false pregnancies, but the medical term is molar pregnancy. It's not going to go anywhere. And so in that way, you propose to terminate the pregnancy. And so you're going to use mechanical methods to evacuate the uterus. What you're bringing to the patient is going to be beneficial. So in that way, you are fulfilling that core value of beneficence to the patient. But what if the patient says, no, I don't want, I want to hold on to this pregnancy to the very end? You let them be, because they have chosen, they have decided to do that. So you do not force them or require them to do what they do not want. These 4 principles of medical ethics are very important. That's the autonomy, non-maleficence, justice, and beneficence. Obviously, there are certain situations where we could have a small discussion. For example, in the young children, it's usually the mother. Because, for example, a 2-year-old boy or a 5-year-old boy may say, I don't want this treatment. But that way, because the child is not yet of age, we usually consider the mother's opinion needs. And as the ages keep increasing, as they come into the teenage life, we have what we call the emancipated youths, depending on the country you're in. Some go as low as 16, others are 15, it depending. So for those, it changes a bit. But in the context of where I am right now, because I'm much more in adult medicine and we are doing with adults, most of the times it will be the patient in front of you whom you'll be dealing with. Or if the patient is unable to make a choice of their own, then you have to work with whom we call a surrogate. But at all times, a good practitioner, healthcare practitioner, is required to make sure that they do maintain the patient's autonomy. When they're interacting with the patient should be left to decide on their own what they desire. Secondly, the health practitioner must make sure that whatever they are proposing to the patient does not cause harm to the patient, that is a non-maleficence. Then thirdly, this intervention that they're bringing on board should be fair and equitable. In other words, it should benefit all populations. For example, an example about that is, for example, the HIV, the new drug we have on the market that has just come in, the Nakaprava. It's the talk of everywhere within Uganda because it prevents HIV and has a very good efficacy of about 99%. So for it to be justice would be to make the drug available to the persons that are highly at risk, that are the people who are doing high at risk jobs, for example, the prostitutes in a layman term, but also make the drug available for the senior sick student who might want to acquire it. So that's making it equitable and fair to make sure everyone does benefit from this drug, because everyone has an equal risk of acquiring a new HIV infection. And then finally, whatever intervention that is being introduced to the patient or suggested to the patient should be of benefit. You cannot introduce something that is going to, that is intentionally meant to make the patient not benefit. For example, I may be a student who is very eager to learn about syphilis. I want to know, how does a patient with terminal syphilis look like? And so it is not good for me to just pick up an injection and I randomly inject someone and I infect them with a syphilis dose so that I could see how they would look like 30 years down the road. That is not of benefit to the patient. Such is not allowed. Therefore, you need to suggest or you make sure whatever intervention you bring on board, it's of good benefit and not harming the patient. The other example I was giving was the HIV preventive drug that has just come in the injectable, that it's of benefit. In other words, for the single mothers who are trying to make ends meet, and they have convinced themselves that the only way they're going to make ends meet is to engage in risky sexual behaviors. When you give them this drug, you are reducing their risk of acquiring a new infection that may have devastating effects on their lives. So that's how we look at it. But when we delve that deeper, when we go in further to dissect beyond the surface, we have issues to do with where we come across confidentiality, and that's why we have the protecting the patient's rights and managing their health information lawfully. And with confidentiality, a good healthcare practitioner should be able to bring it on at the forefront, because sometimes as healthcare workers, we do meet couples, discordant couples. The husband is HIV positive, but the wife is HIV negative. Now, this is a hypothetical scenario. But if the confidentiality, if you can't hold the patient secret, then the patient will not be able to approach you willfully to inform you and tell you everything so that you can treat them successfully to the betterment of the community, because you'll be breaking that trust. So when the patient feels that they are not safe, that whatever they're telling you is not going to be safeguarded between the doctor-patient contract that you are having, then you start coming short, and that's how you end up having certain diseases not being under control. So confidentiality is a very, very key point, and it does come in when it fits in all at the center, and it holds everything together, whether it's going to be the autonomy, whether it's going to be in the non-maleficence, the justice and beneficence that you're executing. Confidentiality is very important, and it's always brought at the forefront. And so that's how I put it in simple terms, that a good healthcare practitioner should be able to hold a patient's, let me call them secrets as they come. But obviously, there are some diseases that are of public health importance for which the confidentiality clause is waived. And apologies for using the example of HIV multiple times, but HIV is one of, there's what we call assisted partner notification. HIV status, we are not required to disclose the HIV status of the husband to the wife as a must, because, I understand most of the people on the space are Christians, so I think they do believe in the whole doctrine of the two become one. But as a doctor, I am not at liberty, neither there is no law that makes me to forcefully disclose that your spouse has HIV, but rather the spouse has to give me consent to inform the partner that your spouse does have HIV. But diseases, for example, like cholera, because these diseases affect almost everyone, those you have to inform the Ministry of Health immediately. This is like anthrax, you do inform. We've had an mpox outbreak. You have to inform the Ministry of Health. So those are certain scenarios where we have some of these some of these pillars eroded. For example, confidentiality. It can't be respected in the event of an Ebola outbreak. You have to inform because everyone is at risk. So those are just some of the few. And that is just an example to show that there are certain scenarios where we have to circumvent these principles, and it's on a case-by-case basis. It's not a one blanket for all. And so the question is, the other question was, what are the foundational ethical obligations of healthcare providers? And these are the four, as I have tried to elaborate, that all healthcare providers are required to stand by those. Any alteration in any of those results into usually the healthcare provider will be sued, and that's common in the Western countries. It's not so much common in Uganda, but it's still it's catching on. Most especially in the surgical disciplines, where there are a lot of obstetricians being sued and surgeons as well. So all healthcare providers are required to stand by these principles. They make a good healthcare worker, and also the community trusts a doctor or a healthcare worker who stands by these principles. So there was a question of how do principles like patient confidentiality, informed consent, non-maleficence and justice guide modern medical practice. They are the root of the current practice. Obviously, the way medicine is being practiced in 2026 is not the same way it was practiced in, let's say, in the 1950s or 1940s. There has been modernization. But still, these principles do hold, and they are the foundations. And they were established following, there were some syphilis trials that were very bad trials that happened in the USA. And so, where there were, blacks who were slaves, they were infected with syphilis, and so there was a cohort, some, zealous healthcare workers infected some blacks with syphilis, and they started studying them, and that caused a lot of chaos. Eventually, when they were auditing what transpired during that era, it was those events that had happened that brought about this universal agreement on the four core principles of ethics. And so these have been carried on, and they keep going on even in this day and age where we're having modernization of medical practice, as well as the introduction of artificial intelligence. These core principles are required to be there. Whenever these principles are eroded, there are lawsuits, and there are quite a number of lawsuits that the public has always won against healthcare workers. And so, irrespective of the timings that keep on changing, the core principles remain. And so, someone asked about how sensitive is health data compared to other forms of personal data. Health data is very, very sensitive because a lot can happen from whether it's going to be weaponization of a community. For example, if I do know that with your genetic makeup you are susceptible to a particular strain, let me give an example. I'm going to give an example of, let's say, a flu. Let's just call it a flu X. And I do know that the people I would like to affect have a particular, let's say, genetic code within their DNA, and that genetic code makes them susceptible to that flu. I can engineer that virus to make sure that it affects those people much more than the others. And so release it in the public, and that way you'd end up having casualties. You just notice that only a particular group of people are passing on. And so health data is very, very vital. You can look at it at all levels, whether it's going to be at the community level or at an individual level. So that was maybe at an individual level where, certain people are more susceptible than the others. But at the community level, health data can, if it's breached, depending on the data you're dealing with. An example would be in the early days of the HIV pandemic. This is in the 80s. There was a lot of stigma that was associated with HIV disease. And so just being labeled that you have HIV alone resulted into someone being separated from community. It was just not good. So they get separated from the community, and that goes down the road. Health data as well, if there was, let me give an example. You remember very well in the COVID lockdown, in the 2020 lockdown that we had, they informed us that if you did not have certain vaccines, if you had not received vaccines for COVID-19, you could not be eligible to leave the country. And so there were health records available. And if you went to the airport, even though you got a visa following your visa interview, if you reached the airport and they checked in the system and they noticed that you had not received the shots that they wanted you to receive, you would not be allowed to get into the plane. And so you had to, step aside or get a shot immediately at the airport and then get onto the plane to move to your destination. And so that's how important health data is, that depending on the user, it can be used for harm or for the betterment of the society. But if it ends up on the harm side, it's usually devastating. It can result into segregation, where you just put aside. And I think you can get the whole picture from that. And then when we asked what are the ethical risks if such data is exposed, so the ethical risks, as let me give, let's say, remember in there were, let's give an example. In the USA during the COVID-19 outbreak, they said if you were not vaccinated, you would not report to work. And so if such data gets out there, you're obviously cut off. You can't come to work, and if you're not reporting to work, your ID is like disconnected from the mainframe right at the office, so it can't work to open the doors for you to clock in, and so you have to go home because you have been blocked from entering. Those are just the simple examples, but there are harder ones. For example, I gave an example of gain of function research, where there are organisms that are being engineered in the laboratory, and these are used in chemical warfare or in bioterrorism. It is possible to use a signature to target someone based on their DNA signature. Just alter the organism to make it more virulent against that individual. And so when it's released in society, everyone gets the flu, but that individual is taken out. That is in the extreme cases. The other way is engineering, let's say, a vaccine. And this vaccine is meant to take out a certain group of people that have a particular allele. So when you do immunize these individuals, for some reason, fertility rates fall in that particular group of people, whereas in the other groups of people, they seem to be doing very well. And so you start noticing, for some reason, the number of children per household in a particular group of people is low, or a particular race, or those who have that particular DNA signature is less compared to the other. And so that's how valuable. For your health data to leak, it's as good as giving yourself over to someone to be in another person's hands. You cannot control. You lose. Chances are very high that you would not have a choice. You may be forced to make a choice because your health data has leaked out there. And so what safeguards must exist before digitalization? Like I did mention, this topic is not, it's not something that is, very far as we are discussing maybe things of 2035. No, this is happening right now. Actually, as we do speak, I don't know if you have seen the news, but there are headlines that move around in the New Vision and Daily Monitor, where they say, "Oh, Ministry of Health has said we are going to switch over to electronic medical records," and people rarely pay attention to that small things. But yes, we have electronic medical records, and they have been sold under what we are using. The message out there is simple. All they want is one, that once we have electronic medical records, we are reducing first. They talk about the climate. Yeah, we're reducing on how much paper we are using and how much waste we are generating. That's one. Then they say if you have electronic medical records, it means that when you enter the system, for example, if you're in Chirudu, if you're in Hospital X and we treat you, you can leave Hospital X and go to Hospital Y, but because you have that particular unique ID, we are able to pick you up in Hospital Y and compare to what we are and pick up your records that were left in Hospital X. In other words, you can easily switch from one hospital to another hospital because of this unique identifier that you picked up from the first hospital you went to. And so these electronic medical records, they're allowing us to, they're also allowing the Ministry of Health to do effective public health surveillance. Because when you show up to the hospital, I receive you as a health worker, I clerk you, make a diagnosis, but I upload it in this mainframe. This on the computer, it goes into the mainframe, and the Ministry of Health can see exactly. So we can tell exactly how many cases of tuberculosis we had from January to June. We can tell how many cases of malaria were around, So we can tell all of that based on the final diagnosis that were made and uploaded into the system. And so that is what is being sold at the forefront, that electronic medical records. We are making medical data to be universally available of all healthcare units. If patients do engage from Hospital X, and maybe they disengage, they miss their visit, they can freely go to Hospital Y and pick up their treatment, or they can continue their treatment from where Hospital X stopped. And so these things are available. It's currently happening. I'm sure you must have come across some, hospitals that are doing this, that are using these systems. Now, what you may not know is that when you enter this hospital, you need to have your national ID. If you don't have a national ID, you need a special waiver from the hospital director to receive medical care. So without a national ID, you can't be given this unique number, And without this unique number, you can't get treatment. No one can even touch you, because the only way Dr. Morris can prove to the human resource manager that he worked and he saw patients is by presenting a worklook for that day that shows that I treated patient number 001 UGX-0225. And so this is happening. It's available with us, and there are national referrals that have transitioned already to the medical side. And so discussing ethics in this day and age is valuable, because many things can happen. For Uganda's case, we are having a private company. I think, it's a private company that is handling the database currently. But I don't want to say much that might incriminate me, so I will stop there regarding that. But just know these things are happening. They are happening with us, and there is already infrastructure available. It's just going to be a matter of time before all hospitals have gone to electronic medical records, and it's just a matter of time before your national ID number becomes the number. I mean, we are seeing it already in taxes. So, okay. Now, so that is what is happening currently with what we have in the country today. And so it's important to know that the ethical principles are being challenged with what we have. For example, if you do not, give an example, if you don't have that particular number, you can't access care, no matter how much you want. Though obviously for those who do not have national IDs, like say even refugees come with a refugee card that is recorded in the system, but if there has to be something, and without it you need special approval. Now, what if they refuse to give you special approval? There are things you should talk about. What happens to you? You lose out on care, and so you'll be lost. You'll be excluded from receiving particular treatment. And then I told you, if the data manager is a private company, assuming the country does not have a very strong cyber network to hold it, it can easily be hacked, and this information can move out. And let me give. So, for example, we assume that in Africa, sub-Saharan Africa, we have a lot of infectious diseases and not necessarily non-communicable diseases. That's the assumption. It means that if the data leaks, that means pharmaceutical companies can tailor the drugs that are being supplied in Uganda. They would say, or the drugs that are in the Ugandan market. So instead of putting antihypertensives, let us change and we make make drugs that treat microorganisms to be more prevalent. So that's something that also that is at risk. And then, like we said, how about surveillance, the privacy of people? For example, obviously it comes off as though we are keeping a national database on disease X, and so we would want to know how people are moving. But it is highly possible that, it starts off like that, as though we are going through disease X. Say, let me give an example. Say monkeypox. Monkeypox is sexually it has that part of, it can be skin contact, but then also anal sex is a risk factor as seen in the homosexuals. So you could enter through saying, I'm going to understand why does Eastern Uganda have a lot of monkeypox outbreaks. And so we enter through that channel. And while we are in it, we now start saying, let us look at the patients who presented with monkeypox. Let us find their biodata. And so we try to look at, we understand that, this was a male who was 24 years old, and this was another male who was maybe 50 years old. Then as we look further, because these digital numbers we are getting in the hospitals are linked to our national IDs, it can easily be a back channel to your national ID, and it's different if that NIN is linked to your ATM or your bank details. So all that can be a portal through which you can be surveilled. So obviously, as a person, your privacy is at risk as well. And like I said, autonomy, your right to make a decision to say, no, I will not. Like I gave you the example, for people who wanted to travel, you had to get a shot. You could not travel unless you had received the shot. And it can be rolled up and say that for a student to join secondary school, they must have all the immunizations of the childhood, all of them, even though some may think that certain immunizations a particular period of time are linked to autism, they lose that bargaining chip to say, no, I will not, because they want to study. And so as a result, their decision making is cut off. I remember very well, still in the lockdowns, when we were forced to stay in the houses, we lost our right to come out to enjoy the community as we had previously. And that is all just a sneak peek of what can happen when we have these IDs. Because now for this particular, you can easily be identified as an individual and you can be dealt with as a person. But by and large, I'm not saying that having these IDs is bad, like I have mentioned, that there is a lot we can get from these things. For example, if it's done very well, it's good first and foremost to have health systems that are robust and modernized. If it's done very well, and the concerns, issues to do, and there is maybe a regulatory body that is keeping the powers that be in check, we can, it's good to know that you don't need to walk around with a file, It's good to know that I can visit this particular hospital today, and if I don't feel like, or if at all I have a party somewhere, I'll go attend that party. And instead of coming back to that hospital, just attend the nearby health unit, because I know my health records in the system. So it does help. It allows for easy continuity of care. And from a program control approach, it's good because it gives you it gives you an easy access of knowing the exact burden of disease, and it's easy to come through and easily quantify and make planning. And maybe we have a lot of TB. Therefore, if for the HIV, TB, and malaria budget, we are going to put a lot of money more on the TB. Or if it's about HIV, we say, okay, we are going to spend more money on on preventing HIV. So it does help. These systems do help. And then even for research purposes, in the future, someone may decide to look back and say, in the last 5 years, I would want to know what has been the trends of a particular disease. And it's easier when there is a central database that you can go to, design a study and do a retrospective study at a go, and easily find the work and then get it published. So yes, having having an improved, efficient healthcare unit that is running on these established systems, as long as they are in check, is really good. And as regards public health surveillance, especially for outbreaks, it's also helpful. For example, I might be in Kampala, and in Bundibujo they register a case of Ebola. I am able to look. I will just know immediately that we have a case of Ebola in Bundibujo. Then we cordon off the whole of that part, or the whole of that western part of Uganda. We cut off road transport so that we can minimize the spread of disease and just put it in one place. So what I'm just trying to say is that these things are good, but when they are not regulated, or if there is no oversight, they can easily become a danger to the society. Okay. All right. I think I have answered quite a number. All right. I would hand over next to you, Ms. Agaba, and thank you.
Thank you very much, Dr. Rutachinjira. Claire, do you have anything? There is a question in the chat room from Pesh. If you can read it for Morris. There is also another question from Martin. Martin says, what are the signs of a slippery slope? What actions might a government take that would signal a shift from public health efficiency to public health surveillance? Pesh asks about the electronic records. Does this mean that every hospital has access to my medical records, even that which I haven't shown up to for their services? Those are the two questions that are in the chat.
Okay, thank you so much, Pesh. I'll start with Pesh because it's a bit direct. The answer is eventually that is the reality. Because when if you look at it from the point of view of the fact that there have been quite a number of outbreaks that have been reported in Uganda, almost every year, it's either going to be yellow fever, Crimean Congo, Ebola, Eventually, all hospitals are going to be on a certain form of mainframe, whether it's going to be, initially it will start as a public thing, public hospitals, then eventually also private hospitals will be. And so that will be it over time. It's something that you should anticipate that is going to happen, because why else would we have Ministry of Health piloting national referrals to have electronic medical records? And that is what they're saying, because they would want someone at Ministry of Health to have access to what is going on within the hospitals. So that's what it means. It means that if you went, for example, I'm going to give this is just a random example, it's not a particular hospital. If you went to, let's say, Churudu National Referral, and you saw a doctor there, over time, another doctor in Mulago will be able to retrieve that just using your ID. We'll be able to retrieve all the medical history that was recorded while you were in the Chirudu Hospital. The other question that was asked, what are signs of a slippery slope that we are moving away from that we're moving towards surveillance? Well, obviously there may be cases. For example, you remember when, let me give you an example. You remember in the 2020 COVID lockdown, if you went, let's say, to LMK and you tested for COVID-19 at LMK Laboratories, it's in Nakasero, and your test came out positive, in the early days, they would link that result to all the Ministry of Health. Like, for some reason, it would be somewhere in the database. If you chose to the point that they would come and trace you down. Likewise, in the when we have these Ebola cases, they usually break up here and there. You're seated at home, you just see health workers knocking on your door and they're screening you. Then they tell you, oh no, it's because someone died in Bujiri Hospital and that person said he was in the same taxi, or he met you somewhere. So when you see those things starting to come up, for example, whenever there is precedent and they're saying that they are using hospital records to track these people down or to follow up, it's usually follow up. It comes off as follow up, but then you start seeing other things coming into play. For example, your education, you can't proceed on your education, or you can't, as a person, make a particular purchase, when such things come, or if they start linking it with something else, then you should have a lot of concern. Kenya has advanced. Apparently, it's easy. They have advanced so much when it comes to integrating their digital platforms, whether it's going to be the bank and the health, so that they know, and insurance, so that they know when you show up to hospital, they will know whether you're covered by insurance or not, so something like that. It comes off as a convenient thing, but you just know that as data gets out there, you are at risk. So there are no clear signs per se, as you'd say that, when you see A, B, C, D, E, then you just know this has happened. But there are certain things that you would notice and you make personal deductions, and you just know that when this happens, as you start observing such things, then you know a particular trend is happening.
All right. Thank you, Dr. Morris. Can you hear me?
Yes, I can.
All right. So I will ask a follow-up question from one of the submissions that you made, but I'll also invite more questions shortly before Dr. Morris gives us his closing remarks. So my follow-up question was on the question that was around the ethical risks, if at all this data, the health data, is exposed, centralized, or misused, what kind of ethical risks are we looking at? And so from your submission, you've highlighted some of the pros of having a central database. Probably it can further research, or it is important in terms of research, but also at the end of the day, given that the information is in a centralized place, of course, it contributes to data analysis, and in one way or another, it enables the whole process of coming up with data-driven decisions. And you later on highlight that, of course, if at all this is not regulated, there are disadvantages, or there is a negative side that we need to be mindful of. So currently, the East African community is coming up with an AI strategy, and the Ministry of ICT in Uganda has also kickstarted the whole process of consulting in terms of coming up with a national AI strategy. And I'm bringing in AI, or artificial intelligence, because, of course, where there is data, somehow the discussion of AI pops in. So from your standpoint as a health practitioner, how would you advise these bodies, even as they are coming up with these strategies? Because you highlight that, yes, there are certain advantages as far as having a centralized database is concerned, but there are disadvantages, right? Disadvantages in terms of what happens at the end of the day if at all this information lies in the hands of the people who intend to use it to cause certain harm at the end of the day, or who might use it to cause some form of discrimination and the likes. So I just wanted to pick your thoughts on how would you advise these bodies as far as regulating this is concerned.
Thank you so much, Claire. It's a hard question, but I'll attempt it. Well, artificial intelligence is good. Definitely, we appreciate what it has helped us achieve in medicine. For example, diagnosing TB in diabetes is very difficult sometimes, and so we rely on artificial intelligence to help us read the X-rays of these patients and gives us scores for which we base on to make a conclusion that this could be TB. And so, yes, that's just one example. And AI scores are used in other things as well. That certain decisions that can be difficult, whether to do a surgery or not to do a surgery, based on the data that is gathered and the algorithms that you're using. And so it is good to know that the East African community is coming together to embrace artificial intelligence. And in line with the discussion today of health, I would say that there is need for an independent, yes, what they're doing is really good, and we thank God for this move and this direction of embracing technology as we move forward. But there is also need for an advisory body that is independent of them, one that can oversee. Ideally, you would wish that that body would be a body of people that have high integrity, those that are elected per se to that body. And for this is to make sure that that this body oversees the work that are being done, or the frame that is being forged, to make sure that, one, there is no forced participation of people, or the masses. So that we preserve their autonomy, to make sure that data is not being misused, so that we ensure that the public's privacy is upheld. You wouldn't want health data to be like certain people to be targeted, because of a particular health condition they do have. You would want to make sure that vulnerable groups are not excluded. Talking about the refugees, prisoners, so that we are, whatever service they're offering is equitable to all, and that whatever ideas are being brought on board do not cause harm or result into denial of health care. And finally, there should be a clear health benefit, more than 50% health benefit for the East Africans. However, that would be the advice, and we hope that such advisory bodies do exist. And not to be a pessimistic person, I know someone would say, someone can buy off the whole body and then, and they turn the blind eye. But we need such a body to exist to oversee these activities that are being done, and to make sure that the integration of this AI in healthcare is being used for the right purposes to improve health of the East Africans. Thank you.
All right. Thank you, Dr. Morris. There is a question from Mr. Movezi. What measures laws are available to safeguard against theft or misuse of sensitive medical information?
That I would have to inquire from a lawyer, definitely. But I'm sure there must be something to do with cyber, maybe like a cyber law. I hope it is there. I have to ensure that there are particular. We have to actually make sure there are laws. That's the other thing. As we embrace this, as our lawmakers embrace these technologies, we have to make sure that there are laws that will keep them in check, to make sure that there are penalties that are of equal measure to a breach of a particular law. So currently I do not know any of it, but I hope they're there. I do anticipate. But as a researcher and a clinician, it's one of those things that I think would be of good interest to the community, because we know the law is for the community, and it's the goal is to bring order to the community. Thank you.
All right. Thank you, Dr. Morris. So right about now, I'll invite you to give your closing remarks, and maybe as you reflect, to highlight what must never be compromised in healthcare, regardless of the technology that is evolving, and what does an ethically sound digital health future look like?
Yes, thank you for giving me the opportunity to talk about this issue. The digital innovations are value to us. There are quite a number of testimonies or good reports that have come out of them, whether it's going to be helping mothers in Western Uganda, teenage mothers not miss their antenatal visits using mobile apps, or helping doctors not to forget clinic visits for patients using particular mobile apps, and helping patients confirm their visits using mobile apps. And even like I gave an example of artificial intelligence assisting in making diagnosis for patients who are at high risk of a given disease. And so these technologies value, and they have helped medicine take a leap, including using computers to read complex digital images and assist in making a diagnosis. So yeah, they are good, and it's good to embrace them. But let's not forget that if not checked, it can be very dangerous in a society. Ideally, would want any intervention, whether it's going to be an electronic medical record that is being pushed by the Ministry of Health. They have to make sure that at the end of the day, this platform that is being built does not culminate into the patient losing their autonomy, losing their privacy, receiving services that are of harm to them and do not give them any benefit whatsoever. That has to be the goal, and it's something that we ought to look out for. Ideally, thankfully, there are platforms like this that do allow us to talk about these issues, and you at the end of the discussion, you're wiser than you were previously, and you can spread word to the next person, and as well promote advocacy for the experts that are at the forefront of these technologies. And I hope people on this space either do take up advocacy, or they know someone that is into advocacy and advise them appropriately regarding this subject. So ideally those would be the characters. Not the system shouldn't breach the autonomy, the privacy, the justice, non-maleficence, and beneficence. And this technology should be used to build society, and specifically to better health within our community. Thank you, Claire.
Thank you once again, Dr. Morris. This has been a very informative session for us, Digital Agenda Forum, and I believe for the audience, as well as those people that will be able to listen into this recording at a later time. And for me, the highlights have really been on the core principles rather, and to the audience, our contribution is very, very key as far as preserving these ethical principles in healthcare, even as we look at digitization. So Dr. Morris has mentioned the importance of autonomy. He has highlighted the importance of ensuring that at the end of the day, the systems that we have do not cause any form of harm, the non-maleficence. At the end of the day, we ensure that we have fairness and equitability, and also to whatever system that is being set in place to be beneficial to the patients, to be beneficial to the end user at the end of the day. So for us as Digital Agenda Forum, this also speaks towards our slogan, which is tech should serve, but not control. So thank you very much once again, Dr. Morris. And thank you so much, everyone, for joining us. We remain Digital Agenda Forum. Have a good evening, good morning, or good afternoon from wherever you're connected. Bye.